Hello, my name is Dr. Aram Jawed. I am a board-certified general and bariatric surgeon working at JFK for life. Welcome to the online seminar. I hope you find it very informative. So what are you going to learn today? Well, what is obesity? Your daily challenges? What is obesity costing you? What are your surgical options? Then we'll summarize everything and move on towards what are your next steps. On the next slide, you're going to watch a video that'll help you understand obesity.
Recent research is revealing the true nature of obesity, shedding light on one of today's most common questions. Why can't I keep the weight off? The traditional view that obesity simply results from a failure to maintain a healthy lifestyle overlooks how the body regulates energy. Recent studies show that weight regulation is a complex process governed by hormonal and neuronal signals between the brain and a system of organs and tissues. New research also reveals that as body fat levels increase, the body adapts and sets this elevated weight as a set point or a new normal. Since this new fat level is recognized as ideal, the body will attempt to maintain it. With this elevated set point, the body defensively responds to even modest diet restrictions by increasing hunger and cravings, decreasing satiety, and slowing metabolism, all to prevent starvation. As part of a basic biologic instinct, well preserved throughout human evolution, even an obese body is programmed to protect fat levels. Because this weight-regulating mechanism does not recognize obesity and subsequently does not allow the return to a healthy weight, obesity presents in patients as a chronic disease. Similar to other metabolic functions, such as blood glucose, LDL cholesterol, and blood pressure, body fat set points are affected by genetic predisposition, environmental exposure, and developmental history. Though all of these factors contribute, the recent epidemic rise of obesity can be primarily attributed to the modern environment. Negative changes include alterations in the chemical and nutrient content of our food, a lack of exercise, high levels of stress, inadequate and disrupted sleep, and the widespread use of weight gain-promoting medications. The result is that many individuals have become obese and, despite efforts to lose weight, remain so or even gain weight due to the compounding effects of metabolic dysfunction. For effective weight loss, calorie intake must decrease and calorie output must increase. However, the obese body treats a calorie reduction as a starvation threat and defends by conserving energy and restoring energy-rich fat. Throughout most of human history, calories were scarce and hard to get, so we have numerous natural defenses against starvation. We have no defenses against overeating because we never needed them. A landmark study of over 4,000 patients found that on average, fighting obesity with diet and exercise alone only achieved a 20-year sustained loss of 4 pounds. The New England Journal of Medicine reported that though dieters may initially lose weight, their bodies then encourage fat regain by triggering a cascade of changes in hormonal and neuronal signaling, which did not return to pre-diet levels even 12 months later. This unrelenting self-preservation mechanism may explain why most weight loss attempts fail in both the short and long term. Successful weight loss is important because obesity has been linked to increased risk for diabetes, an ever-increasing public health threat, as well as cardiovascular disease, the world's leading cause of death. Other diseases related to metabolic dysfunction have also been linked to obesity. The key to reducing these health risks and successfully treating obesity long-term appears to be treatments that change the physiological body fat set point. For many patients, this requires therapies that can deliver long-term weight loss of more than 10%. New research indicates that bariatric surgery, increasingly referred to as metabolic surgery, has lowered set points and had profound metabolic impacts beyond that of weight loss. The surgery changes hormonal and neuronal signals, decreasing appetite, increasing satiety and metabolism, and encouraging healthier food preferences. Positive weight-independent changes, such as glucose homeostasis, lipid biology, and more, have also been observed. The New England Journal of Medicine reported that more than 3 times as many diabetics achieved glycemic control of 6% or less through bariatric surgery versus those who only underwent intensive medical therapy. This new data on the complexity of weight regulation, the concept of set points, and weight loss study results has shown that diet and exercise may not be enough to achieve the most advantageous long-term benefits for obese patients. In contrast, metabolic and bariatric surgery patients experience, on average, over 45% excess weight loss and lower body fat set points. This allows them to successfully keep the weight off, reducing their risks for a host of obesity-related diseases and improving the quality of their lives.
On the next slide, you will see my surgical experience. I am fellowship trained in advanced laparoscopic, robotic, and bariatric surgery. I am U.S. board certified by the American College of Surgeons. I've been certified in robotic surgery. I've presented at multiple national conferences and won awards on my presentations, as well as in surgical competitions. So in summary, you're going to be very well taken care of. So let's discuss various levels of body mass index, or BMI. A BMI is your weight divided by your height. BMI is based on specific numbers, such as a BMI of 30 to 34.9 will put you in obesity class 1. A BMI of 35 to 39.9 puts you in obesity class 2, and a BMI of 40 or more puts you in the morbidly obese category. If you are a female of 5 feet 4 inches tall, then your BMI is 30 at a weight of 175 pounds. Now, as you can see from the chart, if you increase your weight by only 25 pounds, it lands you in a higher obesity category. The higher obesity category that you land in, the more risk you are for diabetes, hypertension, and other comorbidities. Many serious illnesses are associated with obesity, such as type 2 diabetes, hypertension, hyperlipidemia, obstructive sleep apnea, fatty liver disease, which is the most common cause of liver failure in the United States right now. And if you're a woman, menstrual irregularities, such as amenorrhea and dysmenorrhea, put you at risk for infertility as well. There are many other comorbidities from morbid obesity. So you're not alone. More than 65% of adults are overweight or obese. 32% of children are overweight. 4.8% of adults are morbidly obese. And the total medical cost of obesity in 2009 was $147 billion. And last year rose to a staggering $210 billion. 325,000 obesity-related deaths occur annually. So what are the costs for you? Conventional treatments have seriously been lacking. If you look at this chart here, whether it be Atkins, Zone, or Weight Watchers, the weight loss at 1 year is only on average of 5 to 7 pounds. And only 53 to 65% of patients can even complete 1 year of dieting. Your insurance cost also goes up as your body mass index goes up. As you can see here, physician visits, pharmacy, laboratory, outpatient and inpatient visits all increase in percentages between 30 and 35 and 35 and above BMI. So morbid obesity is costing you a great deal. On the next slide, you're going to see a video depicting the cost of not treating morbid obesity.
I have relatives that have high blood pressure and diabetes and all these health issues. And being 51 years old, I'm certainly concerned about those issues. I do not have those issues at this time, did not have them before the surgery, and don't want to get them. So I have to make some life-changing decisions.
Everyone in my family is very tall and has been overweight, and my grandmother passed away of pancreatic cancer, and so we knew that that was mostly due to her being overweight, and we realized that was not the road we wanted to go down. And so my mom and I both decided that this was an important decision for us to make, and it's been the best decision that we've made.
What really inspired me to really get my life under control here, a couple of years ago, my mother had a heart attack. And she stayed in the hospital in ICU and in a room for 73 days. And my family and I, we watched her die on a ventilator. She had, all the comorbidities, hypertension, high blood pressure, significant weight gain, diabetes. She had all that. And I looked at her and I thought, look what my family's going through. And then I looked at my son. I thought, I cannot do that to him. I cannot do that to my son when he's my age.
Now we're going to talk about non-surgical options for weight loss surgery, such as Reshape, which is the non-surgical weight loss procedure as a balloon that goes into your stomach. The Reshape intragastric balloon procedure was specifically designed for people who meet the following requirements: BMI of 30 to 40 with a comorbidity, no previous weight loss surgery, and a willingness to make changes to support a healthy lifestyle. The intragastric balloon is placed into the stomach for 6 months, at which time it is removed. You get 1 year of comprehensive coaching. This helps with portion control, lifestyle change, and has 2 times more weight loss than diet alone. So what are your surgical options? Are you a candidate for weight loss surgery? You need a BMI of greater than 35 with comorbidities or a BMI of greater than 40 without any comorbidities. You need to be healthy enough to undergo a major operation, have failed attempts at medical weight loss, have absence of any drug or alcohol problems, have no uncontrolled psychological conditions, and you need to understand the surgery and the risks. And most importantly, you must be dedicated to a lifestyle change and lifetime follow-ups. The current most used bariatric techniques are as follows. In the middle of the screen, you have the number 1, which is the vertical sleeve gastrectomy, a purely restrictive procedure. On the right of the screen, the Roux-en-Y gastric bypass, which is a restrictive and malabsorptive procedure. And on the left of the screen, you have the adjustable gastric banding, which is a purely restrictive procedure. So let's set your expectations with weight loss surgery. For gastric bypass surgery, you have an 80% excess weight loss at 5 years. For laparoscopic vertical sleeve gastrectomy, you have a 60 to 70% of excess weight loss at 5 years. And for the laparoscopic adjustable gastric band, you have only a 40% of excess weight loss at 5 years. So let's talk about the vertical sleeve gastrectomy. This is a laparoscopic procedure that we conduct with 4 very tiny incisions. It's completely restrictive, and it's the most common procedure conducted in the United States today. You have a mean excess weight loss of 55 to 70%. There's no implantable medical device, and it depresses the hunger hormone ghrelin. Next, you will see a video on how the sleeve gastrectomy is performed.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is mixed with digestive enzymes to help break down the food to a more simple form, so that it can be more easily digested and absorbed when it is in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 and 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. By altering the anatomy of the gastrointestinal tract, sleeve gastrectomy changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. The bile and pancreatic fluid from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments needed for the sleeve gastrectomy. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
So what are your risks and complications of a vertical sleeve gastrectomy? Well, first and foremost is dehydration and nausea. whereas staple line leaks, stretching of the stomach, stoma obstruction, and possible need for additional surgery are extremely rare. There is also minimal required need for vitamin supplementation. So the next procedure is a Roux-en-Y gastric bypass. This is also a laparoscopic procedure with 5 minimal incisions. It is both restrictive and malabsorptive, with a mean excess weight loss of 64% in 10 years. There is no implantable medical device, and it also depresses the hunger hormone ghrelin. On the next slide, you will see a video depicting how a laparoscopic Roux-en-Y gastric bypass is performed.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. The small intestine is separated into 2 sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. The upper portion of the small intestine is reconnected to the lower part of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested. By altering the anatomy of the gastrointestinal tract, gastric bypass changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
So what are the risks and complications of the Roux-en-Y gastric bypass? Well, you have a very low chance of a leak from the staple line, about 0.4%. You also have a risk of a marginal ulceration, which are ulcers around the staple line, which is about 5%, but smoking increases your risk. You also have a risk of a possible internal hernia, which is low as well, at 5%. A specific complication to the gastric bypass is dumping syndrome, which is a self-induced sweating, faintness, and diarrhea, nausea, and vomiting from overconsumption of too much carbohydrates. With the gastric bypass, it is very important to take a daily multivitamin, calcium, and vitamin B12 and iron supplementations. So next we'll talk about the adjustable gastric banding procedure. This is an entirely restrictive procedure. It's the 3rd most frequently performed bariatric procedure in the United States, with an excess weight loss of 25 to 40% at 5 years. The hunger hormone ghrelin levels are actually increased. It requires an implanted medical device and ongoing maintenance, requiring both band adjustments and fills in the office. On the next slide, you will see a video depicting how the laparoscopic adjustable gastric band is performed.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. In preparation for the band, a tunnel is created behind the stomach. The realized band is introduced to the abdomen through a trocar. The realized band is positioned around the upper portion of the stomach and then secured using the locking mechanism. A tube attached to the realized band will be connected to the injection port. The port is used to adjust the band tightness after surgery. An incision is made on the upper abdomen to insert the realized injection port beneath the skin. The tube is secured using the locking connector on the port. The injection port and tube are placed beneath the skin. The realized band does not alter your digestive function. Food consumed passes through the digestive tract in the normal route. Your surgeon may tighten the Realize band by injecting saline into the injection port. As the saline is introduced into the Realize injection port, it travels through the tube to the band. The addition of saline to the band creates a smaller upper stomach pouch. This smaller stomach pouch decreases the amount of food you can eat before feeling full. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
Okay. So what are the possible complications of laparoscopic gastric banding? Well, first you have dilatation, where the stomach or esophagus can dilate above the band. You have band slippage, where the band can slip lower onto the stomach. And you have band erosion, where the band can actually erode into the stomach itself. So when we're discussing band adjustments, if you're losing about 1 to 2 pounds per week, you may not need a band adjustment for some time. Band adjustments usually start 6 to 12 weeks after surgery, depending on each individual's weight loss. Band adjustments are done either in the office or under fluoroscopy with local anesthesia, and it takes approximately only 5 to 10 minutes. Usually, it takes 2 to 4 adjustments in the first year to achieve the desired restriction. And this is all usually covered by insurance. What can you expect after weight loss surgery? Recovery takes time and patience. You may experience discomfort and pain as your body heals. The capacity of the stomach has now changed. The length of time to return to normal activities can vary from patient to patient, but usually it's about 1 to 3 weeks. Your healthcare team will advise you when to return to work, resume prior activities, and schedule your follow-up appointments. Most patients see weight loss of about 10% of their weight in the first month. So let's look at some of the resolutions of comorbidities after bariatric surgery, specifically obstructive sleep apnea with 74 to 98% resolved, non-alcoholic fatty liver disease, which I said was the most common cause of liver failure, up to 40% resolution, type 2 diabetes, 82 to 96% resolved. Most of our patients leave the hospital free of any diabetic medications. Osteoarthritis and degenerative joint disease, 41% resolved, and metabolic syndrome, 80% resolved. And as you can see, there are many others that involve every body system. First, you have to choose a procedure that's right for you. The considerations on an individual basis are: what are your age, what is your health risk, depending on your own comorbidities, your amount of weight that you want to lose, and your goals, your lifestyle, and your eating behaviors. This is going to be a mutual decision between yourself and me, and we will discuss at the initial consultation. And you can discuss with family and friends. So what are your next steps? We have a bariatric success program here at JFK for Life, and we treat patients preoperatively and postoperatively with multiple routes of surgical support. The bariatric success program pre-surgical, we have a one-stop shop for your convenience. The surgical consult, you can get to know me. Is this right for you? What is your best surgical option? Do you have any additional questions after watching this seminar? You'll have a nutrition evaluation, which will educate you on the bariatric diet pre and post-surgery, answer all of your questions, and make sure that you have a very high level of understanding and commitment. And you will also have a psychological evaluation to see if you have any issues and if you have a very good support system that can help you throughout the surgery and keep the weight off after surgery. So the Bariatric Success Program after surgery entails monthly support groups that are all free. We discuss comprehensive lifestyle support, education, and motivation. We want to make lifestyle fun and achieve a high quality of life. On the next two slides, you will see contact information for key personnel at the JFK for Life Surgical Weight Loss Program. Thank you for your consideration in viewing this online seminar. I hope you found it informative. I look forward to our consultation in the office as we begin your journey to successful weight loss.